Hello and welcome to Toronto. This is World Parkinson's Program Facebook Live session. We will be speaking about Parkinson's disease and its various aspects. We will also take questions in between as we go. We get asked quite often that how a patient can participate in their treatment, or what role a patient can play to improve their treatment. A patient is an important part of the team. The treatment of Parkinson's disease is a team approach. It's a multidisciplinary treatment. The active participation of patient is very necessary. First of all, patients should have the correct information about the disease. They should try to learn more about various aspects of Parkinson's disease. They should make a note of any questions they have in between when they are seeing their neurologist, and they should try to write down these questions, because if they don't write, they might forget when their appointment comes. So that's one thing. And then patients should also note that certain medications they are taking, how it is affecting their treatment, if they are developing any side effects, or how much a medication is effective. That's an important information to relay to their healthcare team. And if patient notices any new symptoms in between, suppose if they get any foot cramping or pain in their legs or feet, or any other new symptom which they never had, they might think that this is not related to Parkinson's disease, but it's good to write it down and then speak to your neurologist when you see them at the follow-up visit to see if that symptom is related to Parkinson's disease, and if it is, then if this symptom can be addressed. So the involvement of patient is as important as the involvement of the physician or the care partner in the course of the disease, and as long as its treatment is going on. We also get asked by people that how is Parkinson's diagnosed? Like they have many symptoms. I was at a seminar speaking yesterday, and people were saying that could a diagnosis be made based on symptoms like constipation, or we spoke about non-motor symptoms there, so they were asking that based on a runny nose or based on drooling or constipation, can we make a diagnosis of Parkinson's disease? So it's important to note that Parkinson's disease has two types of symptoms, motor symptoms and non-motor symptoms. We did discuss this before many times. So the motor symptoms of Parkinson's disease are slowness of movements or bradykinesia, tremor, which is usually a resting tremor, and it starts usually on one side of the body, involving mostly a hand or arm, or maybe leg in some cases, or lower limb. So this is a very fine or small or mild amplitude tremor in the beginning, and then it develops slowly, and is commonly referred as resting tremor. The stiffness of the muscles, which also starts usually on one side of the body, and balance problems which start late in the course of the disease. So these motor symptoms of bradykinesia or slowness of movements, resting tremor, and stiffness, these are the main symptoms which are assessed by the physician, and the diagnosis of Parkinson's disease is usually made once patients have a few of these symptoms. So if they don't have any motor symptoms, but they have symptoms like drooling or constipation or toe curling or pain, so then the diagnosis of Parkinson's disease cannot be made, and the physician may need to assess you again over a certain period of time to see if you develop any motor symptoms. So the diagnosis does rest on the motor symptoms of Parkinson's disease. The non-motor symptoms help physicians to support their diagnosis sometimes, and some patients may not have many non-motor symptoms. So still, if they have the important or cardinal motor symptoms, the diagnosis of Parkinson's disease would be made. We have a question from someone, and they are asking about hallucinations. Yes, hallucinations are non-motor symptom of Parkinson's disease. The common type of hallucinations in Parkinson's disease are visual hallucinations. By visual hallucinations, I mean that patients would report that they see things which don't exist. Sometimes they see people who don't exist. They would report that they meet people or they see people in the house, and no one else can see these people. And at times, the people they see, they might have passed away a long time ago. They see relatives or their parents who passed away a long time ago, and they see them in the house, they visit them, and occasionally patients will report that they talk to these people, and other patients may see animals, or they might see other things which don't exist. And some patients would have a false perception of an image, illusion, such like if a curtain moves, they might feel there's a snake there or something there, and they get quite anxious. The visual hallucinations are the most common type of hallucinations in most patients of Parkinson's disease. The other type of hallucination, such as auditory hallucinations, hearing things which don't exist, could happen in Parkinson's disease, but the auditory hallucinations are much less common as compared to visual hallucinations. The visual hallucinations are usually detailed in Parkinson's disease, and they are not frightening in most cases. Most patients, after you explain them, they may understand that these are not real, and they don't get frightened. There could be some patients who may have very detailed and well-formed hallucinations. We had a patient, she used to name the people who she would see, and she would say that she sees angels, and she would name these angels by the name that such and such angel visits me. So they could be sometimes detailed, and they could be well formed, and the family members may be disturbed more than patients. Sometimes they might try to explain, and patient in the beginning may not appreciate that these are not real. However, after some time, they start believing that they start knowing that these are not real. So the visual hallucinations are treated with medications. First of all, the physician goes through the list of the medications. If there are any of the medications which have high potential to cause or increase the visual hallucinations, so these medications are adjusted, and if they still don't improve in spite of screening of other medical and health issues, then patients may be treated with medications. There could be certain medications for Parkinson's disease which have more potential of triggering the hallucinations. Some of these may include anticholinergic medications. Anticholinergic medications are used mostly to treat tremor of Parkinson's disease. These medications are used less often. However, in some cases, if the tremor is refractory, or can be controlled with other medications. Some time the anticholinergic medications may be tried, and these medications can cause resting tremor. These medications can cause visual hallucinations. The treatment of visual hallucinations sometimes can be quite simple. We have a question from someone. What is the best treatment for REM sleep behavior other than medications? My mom has PD and dad is a caregiver. So REM behavioral disorder, we will talk about it a little bit so that everyone can benefit. REM behavioral disorders are sleep-related phenomena. So these patients are usually reported by the spouse or caregiver that when sleep they talk loud, and sometimes they are flailing their limbs. In certain cases they may be punching the bed partner, or they may be thrashing their limbs, and in extreme cases these people can fall out of bed, or they can get injured. When patients wakes up in the morning, they may not recall that anything like this has happened. So these patients may be enacting upon the dreams during the night time. These problems have to be screened by the physician. When patient comes to see the doctor, the physicians should assess by asking questions related to sleep. If they have any difficulty falling asleep, or when they sleep, if there is anything abnormal the family members or spouse notices, so then they would bring out this type of information. REM behavioral disorders should be treated, especially if they are significant. If they are talking occasionally or moving slightly, they are safe, and patients, then they should be offered the option of treatment versus just observation if they become more of a problem. If patient is safe and the care partner is not being disturbed by this or bothered, then one can observe closely, and if they are not happening so often. But if there is a risk of injury, or if this is happening very often and the family is getting disturbed, then definitely these should be treated. The treatment of REM behavioral disorder is usually with medications. The most commonly used medication is clonazepam. However, sometime with REM behavioral disorders, there could be other sleep-related issues such as sleep apnea or other parasomnias. So a overnight sleep study in a sleep clinic is always helpful. Without medications, it's quite difficult to treat these problems. Melatonin can be used for inducing sleep in many cases, but I'm not sure if this would be helpful for REM behavioral disorder. The REM behavioral disorder could be a problem for a caregiver, as I just said. So we'll go back to the question of, we were discussing hallucinations. The visual hallucinations are seen in other medical conditions as well, such as schizophrenia, but these patients don't have other features of Parkinson's disease, and the patients with schizophrenia would have other types of hallucinations as well, such as auditory hallucinations or command hallucinations. There is a full criteria for diagnosis of schizophrenia. Also, sometimes the question comes that how the oral health is affected in Parkinson's disease. We have a question here. My grandfather started falling. Is it related to Parkinson's disease? Falls are not uncommon in Parkinson's disease. However, they don't happen in the beginning of the condition. In in idiopathic Parkinson disease. If a patient starts getting falls in the beginning of Parkinson disease or Parkinsonism, then it could be atypical Parkinsonism. Balance problems usually start after a few years after diagnosis of Parkinson disease. Since these patients have a slow speed of walking, they have short stride, their base is narrow, and one side of the body is affected more than the other side. So there is asymmetry of the symptoms. So all these things, and patients have difficulty turning. Sometimes they could develop freezing of gait, which is a sudden arrest of mobility. So these phenomena, they when affect a patient, their balance is affected, and they start falling. Many patients with Parkinson's disease start falling as the course of the disease progresses. It's usually related to Parkinson's disease. There could be some other factors which can lead to falls, such as if a person has muscle weakness, if they have trouble with their vision, or if they have arthritis, or if they have nerve damage, polyneuropathy in their legs, in their feet, and they have lack of sensation, so they don't know where their feet are in the space. So then there is a lack of connection between the feet and the joints and the brain, so that leads to falls as well. Falls related to Parkinson's disease should be screened by physicians, and they can be prevented. Fall prevention strategies are very important to discuss with patients, such as when they are walking, they should use a walking device such as walkers, and the walkers can be of many different types, four-wheel walker, two-wheel walker, or walkers without any wheels. So a physiotherapy consultation is important to see what type of walker is useful for a certain patient. For example, patients who are quite slow, and if you use a four-wheel walker which goes a little bit fast, that can lead to falls as well. And in some cases, if patients have a lot of freezing and they're quite slow, then a walker without any wheels might be helpful. So falls become an important problem because they can lead to injuries. They can lead to fracture of bones. Patients can have head injuries, and once patients get head injuries or they get fractures, they have to be hospitalized. And once they are hospitalized, I tell my patients all the time that you should try to stay out of hospital as best as you can, since if you go to a hospital, then hospital is not a place where healthy people come, and you can catch the diseases from other people, and you go healthy, and then you become more sick, and sometimes it can lead to long-term hospitalization. So to avoid falls, patients should be very cautious. When they are turning, they should turn slowly. Use of walking device all the time. They should be supervised if this becomes a further problem. And patients should be especially cautious when they stand up from a sitting position, because the blood pressure might drop. And some patients who are taking medications for blood pressure, they might experience this more. So blood pressure medications need to be assessed by family physicians as the time goes by, because of autonomic dysfunction. The blood pressure falls slowly by itself in most patients with Parkinson's disease, and on top, if they are taking blood pressure medications which are not adjusted, then this can lead to further lightheadedness. And patients, after finishing meals or having bowel movement, they should be especially cautious when they are arising. Other time when falls occur is nighttime. So the falls at nighttime are not uncommon, because it's dark. Patients are waking up alone and go to washroom. They were supine for some time, and they stand up. And if they don't use a walking device, or if no one is accompanying them, that could be risk for falls. So we would be wrapping up slowly. If there are any questions, please do write them down. And for next session, we will entertain your questions in between if you have any suggestions or any remarks about improving our live sessions. That would be greatly appreciated as well. So thank you very much, and would see you next time, and have a good week.